Welcome back to the module on acute lower limb ischemia. Okay, describe the causes, clinical features, investigations, and how to manage a case of acute lower limb ischemia. Right, acute lower limb ischemia. So first we are going to look at the causes of the acute lower limb ischemia. Causes, I am broadly dividing this into two categories. One is due to embolus and the other is due to thrombus. Okay, the ischemia may be due to embolus or may be due to thrombus. I am dividing into two categories and we will look into the causes individually. So first one is causes. Causes under which first I am dealing with the embolism and the other is thrombosis. First, looking at the causes of this embolism. Suppose, let me draw you heart for your understanding. This is your heart. Schematically, I am dividing it into 4 chambers. Suppose whenever there is ineffective contractions of the heart, what is going to happen? The blood which has to pass to the next chambers cannot pass easily. So there will be accumulation of blood. Accumulation of blood can lead to a clot formation in the future. Okay. Now, if at all I take an example of atrial fibrillation. In atrial fibrillation, there are contractions, but even there are more than enough contractions. Around 200 contractions, 200 to 300 contractions per minute also can occur in case of atrial fibrillation. But the thing here is, even though it is contracting 200, 300 times more than that, the contractions are ineffective contractions. Okay, due to this ineffective, even though they are contracting many times, they are ineffective contractions. That is the reason why there is always a risk of clot formation in atrial fibrillation. Next one is mitral stenosis. Okay, whatever it is, whenever there is a clot which has been formed here, whenever there is a clot formation, afterwards it can be dislodged from that place and it can get occlude the some other vessel. That is how it is forming the embolus. Okay, now what are all the various causes we are enlisting here? In the heart, it is atrial fibrillation, mitral stenosis, and even myocardial infarction, also the same thing. Myocardial infarction. Okay, these are the things we can see due to the problem in the heart. Coming to other causes, even within the aneurysm. Okay, within the aneurysm also, there is a risk of this. Due to this aneurysm also, it can get embolized. Now, coming to atheromatous plaque. To be frank, I should not write this atheromatous plaque in the embolus. I should write it in the thrombosis. Why? Because atherosclerosis, you already know, it is the sclerosis of the, okay, atherosclerosis, what happens? There will be thickening of the arterial wall. Okay, but it usually causes what? Chronic lower limb ischemia. Okay, atherosclerosis always causes, almost it should cause chronic lower limb ischemia, but sometimes what happens is there can be this atheromatous plaque which can be cut off from that place and it can occlude some other vessel which leads to acute ischemia also. Okay, even this within the artery there is atheromatous plaque. Even this plaque may get cut off and it goes and occludes the other vessel, leading to embolus formation. Okay, this also can occur. But usually atherosclerosis should cause chronic lower limb ischemia. Now coming to any emboli which is coming from the myxoma of the heart. Okay, usually myxoma is more common in the atrial myxoma, right? Atrial myxoma can also lead to this embolus formation. Coming to thrombosis, if you ask me, certain conditions I am going to tell you where there is always a risk of thrombosis in that patient. First thing is, you already know this entity, polycythemia rubra vera. The patient is at risk of thrombosis. You already know patient presents with headache and all those things. That is polycythemia vera. And even in some cancers, even in some leukemias, there will be increase in the platelets and all of those things can be there. There is a risk of thrombosis. Next, you already know this, oral contraceptive pills or estrogen containing pills, oral contraceptive pills, there is always a risk of thrombosis. And I have already told you just now, even in atherosclerosis itself can cause a thrombosis also. These are all the various other causes which are leading to embolus or thrombosis, which are capable of causing acute lower limb ischemia. I want you to remember all these causes. Okay. Now coming to what are all the clinical features with which the patient is going to present to us. Remember, any patient with ischemia, there will be always pain. The moment blood supply is reduced, obstructed hernia, pain. Torsion testis, reduced blood supply, pain. Okay. Here also, acute ischemia, pain. Okay. Whenever there is ischemia, there should always be pain. Now, what can be the other things which we can see? Pallor. Whenever the blood supply is reduced, that part which is affected will get paleness or pallor. And even there can be paresthesias also. Paresthesia, there will be numbness, there will be paresthesias, these things can occur. And distal to the obstruction, what happens is, as the blood cannot flow distal to the obstructed part, there can be an entity of pulselessness can be there. You cannot feel the pulse distal to the obstruction. And you can see paralysis also. Paralysis, or you can call paresis, whatever. Even paralysis can also be seen in acute lower limb ischemia. These are the various P's. 5 P's, tell me. Pain, pallor, paresthesia, pulselessness, and paralysis. These are the 5 P's. Very important 5 P's you have to remember. The skin of this patient, due to ischemia, the blood supply is also very less. Due to lack of blood, you can see the cold skin. Okay, the skin is going to be cold. Now, after looking at the various clinical features, now we will go to how to investigate this case. Investigating a case of acute lower limb ischemia, without any doubt, the first and the foremost step is Doppler ultrasound. Doppler ultrasound is the first investigation. Now I can do digital subtraction angiography, DSA, digital subtraction angiography, in case of aortoiliac involvement. If it is involving the aortoiliac vessels, then I have to do digital subtraction angio. And the other thing I can do is CT angio is also the best investigation is to get a CT angio. These are all the investigations. Now coming to how to treat a case of acute lower limb ischemia. Any case of acute lower limb ischemia, the first step, very important, first step, it is not thrombolysis, it is not embolectomy. The first step is always intravenous heparin. So acute ischemia anywhere, acute lower limb ischemia, first step in treatment is always intravenous heparin. 5000 units, if you want you can remember, 5000 units of intravenous heparin is the first step you have to do in treatment. Now after this, what I have to do, I have given intravenous heparin to the patient. Now what I have to do means, now I have to try to find the cause, try to find out the cause of why the ischemia has occurred. I will try to find out the cause. I will take history, I will do examination of the patient, and whether it is a unilateral lower limb ischemia or whether it is a bilateral, all those things I am going to do, and I am going to evaluate for the cause of this ischemia. Next what I have to do means, next I have to do some investigations. I have to get a blood count. Just a few investigations I am mentioning, not only this, some other things also will do, just basic investigations. I have to do echo. I have already told you heart conditions like atrial fibrillation, myocardial infarction, whenever there is ineffective contraction of the heart, all these things can lead to that. So I have to get a echo, 2D echo. Next, ECG is also very important. Why? Because atrial fibrillation and all I can diagnose on ECG, and I have to get a lipid profile to know about the cholesterol levels within the patient. Okay. Now serum creat also I have to do. Why? Because whenever there is an entity of ischemia, there can always be a possibility of injury to the muscle. This muscle injury can lead to rhabdomyolysis. Okay, this can lead to rhabdomyolysis. That is why renal function test I have to do to assess the rhabdomyolysis. Why? Because whenever the muscle is going to be injured due to ischemia, the muscle is going to die, which causes rhabdomyolysis, and acute renal failure also is also possible. That is why serum creat measurement is very important in this patient to assess rhabdomyolysis. Now after all these things, I have, based on the arteriography findings, my treatment is variable, whether it is a embolus or whether it is a thrombus. Okay. Now there is a classification based on which we are going to treat this. Okay, what is that? The name of the classification is Rutherford classification. Very important. Rutherford classification. In this Rutherford classification, we are dividing it into 1, 2A, 2B and 3. 1, 2A, 2B and 3. These are all the classes in the Rutherford. What is 1? 1 means it is completely viable. Okay, if the tissue is completely viable, I am going to call it as 1. If the tissue has already died and it is an irreversible death. So if it is an irreversible damage which has already occurred, then I have to place it under 3. Okay. If it is marginally threatened, it is 2A, and if it is immediately threatened, then it has to be 2B. Okay. Now coming to how will be the sensory loss in all these cases and how will be the motor loss in all these cases. I am not drawing the entire table for you. I am just highlighting what are all the important topics. Now, with the common sense, please tell me, will there be any sensory loss in 1? Okay, in class 1, will there be any sensory loss? The answer is no. It is very clear. It is class 1. It is a mild, the tissue is completely viable also. There won't be any sensory loss also. Whereas coming to 3, there will be profound sensory loss in class 3. In 2A and 2B, you can write none, or you can write mild sensory loss, you can write. Coming to motor loss, now again with common sense, tell me, will there be any motor loss in class 1? The answer is no. Will there be motor loss in class 3? The answer is yes. It is completely paralyzed. Okay, the limb is completely paralyzed in case of class 3. Next, coming to Doppler findings. On Doppler, I have done Doppler. Coming to Doppler signals within the artery and within the vein. Now, in class 1 is almost completely normal. So I can listen Doppler signals in the artery as well as in the vein also. If they are audible, in both artery as well as the vein in case of class 1, and both of them are not audible, or I can write inaudible. Even artery cannot be audible and venous also is not audible in case of class 3. Okay, in all these things in the middle, marginally threatened and immediately, you can write yourself. Okay, nothing much to discuss in the middle. Okay. Now I have already told you this classification. 1 is viable and the 3 is completely irreversible. In 1 there is no sensory loss, there is no motor loss, whereas in 3 there is profound sensory loss and there is paralysis of the limb also. Coming to Doppler signals, whereas in 1 the artery and the vein, both the Doppler signals are audible, whereas in class 3 both of them are not audible. Right, now with this basic things in mind, what I am going to do is, first one is, in class 1 there is no immediate threat to the patient. Okay, you can understand this. There is no immediate threat to this patient. So after getting a angio, what I have to do, I have two options. I can do thrombolysis, or I can even do embolectomy. Okay, it's my choice. Why? Because it is only a very mild one. Okay, I can either go for thrombolysis or I can go for embolectomy also. Coming to stage 2A and 2B, I have to do angio. After getting angio, now I have to do embolectomy only. Okay, I cannot use intraarterial thrombolysis as the treatment. I have to go for embolectomy if it is class 2A or 2B. Sir, what about class 3? Sir, what about class 3? In class 3, should I do embolectomy? Even embolectomy cannot help this patient. Why? Because the irreversible damage has already occurred. The sensation is already lost. The limb is already paralyzed. There are no arterial signals audible, no venous signals audible. This limb cannot be salvaged. It is always better to amputate this limb. Okay, it is always better to go for amputation in class 3. Okay, our decision varies whether it is class 1, class 2A, 2B and class 3. In class 1, I have both the options: medical treatment, thrombolysis, intraarterial thrombolysis, and I can do embolectomy also in class 1. Whereas class 2A and class 2B, I have to go for embolectomy, obviously after getting an angiography. Now coming to class 3, whatever I can do, thrombolysis and embolectomy, they are not going to help the patient. I have to go for amputation. Why? Because the irreversible damage has already occurred. This is Rutherford classification and how to treat the various things you already know. Now few points about thrombolysis and few points about embolectomy we will look into. Coming to thrombolysis, the better word I can use is intra-arterial thrombolysis. This is the better word. Intra-arterial thrombolysis. Sir, why are you using intra-arterial thrombolysis? The word intra-arterial, why you are using? Why? Because what I am going to do is at arteriography, what I am going to do is I am going to pass my catheter. Catheter is going to be passed. Where I am going to pass my catheter into? Into the occluded vessel. Passed into the occluded vessel. Within the occluded vessel, now I am infusing what? Tissue plasminogen activator. Very important. Tissue, what is the drug used in thrombolysis? Tissue plasminogen activator, TPA. Okay. I have to do arteriography. I have to pass the catheter into the occluded vessel, and then I have to inject what? Tissue plasminogen activator. That is why I am using the term intra-arterial thrombolysis. Can you tell me what are all the contraindications for thrombolysis? What are all the contraindications for using this tissue plasminogen activator? Okay, contraindications for thrombolysis. Can you tell me? Very important. Recent stroke patient. Recent stroke, maybe in the past 21 days or so. In the past 21 days, if the patient has any recent stroke, you cannot use this. Recently, the patient has underwent major surgery in the past 1 month. Okay, in the past 1 month or so, if the patient has underwent any major surgery, then thrombolysis is going to be contraindicated. And even if there is any bleeding, even in bleeding conditions also, if there is any bleeding diathesis also, thrombolysis is contraindicated. And the other thing is pregnancy. There are many other contraindications also, but I have listed only 3 or 4 important ones. Okay, if you remember this, then it's fine. Recent stroke, recent major surgery, bleeding diathesis, pregnancy, and even some things like myocardial infarction recently, or many other things will be there. But these 3 to 4 causes, 3 to 4 conditions are very important. You have to remember. Now, I have already covered embolectomy in a different module. Okay, I'm not going to teach you again that, but just wait. If I have a picture, I can share. Okay. Now, I have already dealt with embolectomy completely. Already I have dealt that in a different module. Just I'm showing you what I have dealt. Embolectomy, acute lower limb ischemia. Obviously, the first step is intravenous heparin, 5,000 units. Now we have options embolectomy and thrombolysis. Now coming to embolectomy you can do it under local anesthesia, or you can do it under general anesthesia. Now, how to perform this procedure? The first thing is you have to do arteriotomy, means you have to give a incision. You have to give incision within the artery. After that, what to do? You have to pass the catheter. Sir, what is the name of the catheter? Very important. Fogarty's catheter. Fogarty's catheter. I am going to insert. After inserting this Fogarty's catheter, okay, I have to pass this catheter, Fogarty's catheter, distal to the, I have to pass this distal here till here, distal to the clot I have to pass. After passing distally, then I have to do what? I have to dilate the distal part. When I am going to do dilatation distal to the embolus, slowly I have to pull the catheter back, which also brings the clot along with that. Okay, this is how embolectomy is done. Okay, we have already seen the entities. Thrombolysis also we have seen, and now we have already seen embolectomy also. Okay, thank you for watching.